we are moving on to the fag end of endocrinology chapter, and we're going to close down the chapter with our discussion on diabetes mellitus. Diabetes is important not just because it's one of the most commonly encountered metabolic disorders in clinical practice. It is also important for the fact that it's one of the leading killers in the world, and it's one of the most common cause of morbidity and mortality in the world. Even if you take the COVID era and see, the most common and the leading killer in the world will be diabetes and its related causes. Such is the importance of the disease and the impact of the disease on the healthcare cost and burden. So you have to understand the details of this disease from the root level itself, and you have to successfully treat the patients. And understanding about diabetes is not only important for a successful practice, it's also important for our personal satisfaction as a physician. So let us discuss in detail about the diabetes mellitus in the few series of chapters which we are going to discuss. And at the same time, we'll start with the very, very basic drug protein molecule that is associated with diabetes, that is the insulin. Insulin, rightly called as a wonder drug, because its discovery is the one that changed the face of allopathic medicine almost near completely. And even though a lot of discoveries are there which change the face, but insulin is one of the discoveries that completely changed the face of how people looked at allopathic medicine. Because those days, diagnosis of type 1 diabetes mellitus is like a death sentence. People inevitably die and succumb to the disease. And discovery of insulin has changed it completely. And insulin injections made these patients survive and live to the level of normal life expectancy. Such is the power of insulin. So that's why it's one of the landmark discoveries in the history of allopathic medicine. So let us start with it. And as I told you before, type 1 diabetes mellitus those days did not have any treatment, and it's like a death sentence. And once somebody gets DKA with type 1 diabetes mellitus, it is like death. That's all. So entering a DKA ward is like entering a graveyard. So they don't come back alive. So this is the first such boy who entered the DKA ward and came out alive. And this is one of the landmark photos that you have to know, because this is again one thing that made the entire world turn towards allopathic medicine. And we know these two faces, very common in many physiology labs, diabetology labs, where you can name them easily. This is Frederick Banting and this is Charles Best, who are involved in the extraction of insulin. And these are the four faces that are associated with the discovery of insulin. First one is Frederick Banting, second one is J.J.R. MacLeod, third one is Charles Best, and fourth one is James Collip. Why they're important? Because Banting is the one who came up with the idea of extraction of insulin, obviously the most prominent face in the discovery of insulin. And second one is J.J.R. MacLeod, who is considered to be the mentor of Banting, and he is the one who provided the lab for the experiments done by Banting. So he's the third person, who is Charles Best, and he is considered to be one of the most important student helpers of Banting. And he's James Collip. James Collip is important because he's the one who helped in making the extraction did by Banting and Best to a much purified one, so that it has its more efficacy. And Banting and MacLeod are the ones who received Nobel Prize in 1923, and Best and Collip did not receive. And no worries, Banting shared half of his prize with Charles Best, and MacLeod shared half of his prize with James Collip. Even though Banting and MacLeod were a little close initially, but later on as times went by, relationships were not fruitful, and there has been a lot of confrontations and disputes between the two. And it went on to a level where, when there was a Nobel Prize ceremony in 1923, MacLeod attended it, but Banting did not attend just because MacLeod is coming. So, I mean, we don't want all those things, but anyways, finds a very interesting piece of history, that's why. And disputes are always interesting for Indians. And these are the two people, again, you must be knowing them. One is Charles Best, of course, on the left, and on the right, you will not be heard much about him. He is Clark Noble, who's considered to be one of the most unlucky persons in the universe those days. Because Banting asked one student helper from J.J.R. MacLeod, and MacLeod provided two student helpers. One is Charles Best and second is Clark Noble. But Banting wanted only one. So they decided who's going to work with Banting by a coin toss. So Best won the coin toss, and Clark Noble did not win the coin toss, and the rest is history. We know that who won the Nobel Prize and who was the prominent face in the discovery of insulin later on. And the last picture is again James Collip, who is the one who helped in extraction of insulin into a much purified way. And this is the famous dog, the dog number 92, Yellow Collie, who played a very important role in discovery and their experiments. And of course, on the right, you can see Frederick Banting. On the left, you can see Charles Best. And this is another landmark photo, which is again very popular and viral during those days. This is a boy who received the first shot of insulin from Toronto in Canada. And because actually Banting did his experiments in Toronto in Canada only. And his name is Leonard Thompson. He's a 14-year-old boy suffering from type 1 diabetes mellitus. And after receiving insulin, you can see his transformation within a few months. It completely changed the face of type 1 diabetes mellitus patients. And he went on to live up to 26 years. Ultimately, he succumbed to pneumonia, unfortunately. And this is another important phase that you have to know. Her name is Elizabeth Hughes. And she's one of the big shots during those days. And she had type 1 diabetes mellitus, which was diagnosed at 11 years of age in 1918. And those times, the only treatment available for this type 1 diabetes mellitus patients is a diet type called as a Frederick Allen diet, which is basically called a starvation diet. During those days, they thought that glycosuria is the problem in diabetes mellitus. They don't know that is diabetes. It's glycosuria that's the problem in these guys. And because of the glycosuria, they lose glucose in the urine and they die. So that's what their thinking is. And they don't know anything about insulin. So they don't know that glycosuria is an effect of diabetes and not the cause. They believe it's a cause of diabetes. So they wanted to reduce the glycosuria, which can improve the life expectancy and ultimately save the patient. That's what their thinking is. So what they did is they reduced the calories in the diet and completely they got rid of carbohydrates so that you don't get glycosuria. But ultimately, you will treat the glycosuria to a large extent, but patients will not have glycosuria. But because they don't have calories and insulin deficiency in type 1 diabetes itself is a severe catabolic state, they ultimately go for starvation and they will die. Actually, this Frederick Allen diet is like a punishment. It's like suffocation and it's like agonizing thing. So over a period of time, they will die, even though it improved the life expectancy by 3 to 4 years, but ultimately they die a very painful death, starvation kind of a death. So that's why she was one of the ladies, one of the VIP citizens in the United States because one of the daughters of Secretary of the State who received insulin while she was actually having this Frederick Allen's diet and improved dramatically. And she was estimated to have received at least 42,000 insulin shots in her life and later on went on to live up to 74 years of age with type 1 diabetes mellitus receiving only insulin. So such is the power of insulin. And after knowing the history of this wonder drug, let us move on to the structure of insulin. We know insulin has two chains. One is the A chain and second is the B chain. And the A chain is going to have 21 amino acids and the B chain is going to have 30 amino acids, making a total tally of 51 amino acids in the entire insulin molecule. And the protein nature of insulin was originally identified by Richard Somogyi, where we still have something called a Somogyi effect, which we'll be discussing later on. So Richard Somogyi is the one who first told the protein nature of insulin in 1924 after the discovery by Banting and Best. And later on, many subsequent discoveries came, crystallization of insulin came, and the entire structure of insulin was actually sequenced by Frederick Sanger in 1951. And we know insulin is also going to have two disulfide bonds between the A chains and the B chains at A7 and B7 position and at A20 and B19 position. So between the two cysteine molecules between A chain and B chain. Clear? So disulfide bonds means it's between cysteine residues only. A7, B7 and A20 and B19. And the third disulfide bond is there, but that is between the A chain. That's called intrasulfide disulfide bond. Intra-chain disulfide bond. That is between A4 and A11. And the total molecules weight, insulin molecules weight is considered to be somewhere around 5.8 kilodaltons or 5,808 daltons to be precise. So final take home point, insulin, A chain, B chain, A chain 21 amino acids, B chain 30 amino acids, two disulfide bonds between A chain and B chain and one intra-chain disulfide bond between the A chain itself. And how insulin is going to get secreted. So let us start with the insulin gene for that matters. And obviously we know every eukaryotic gene is going to have a promoter. And this promoter is actually influenced by a variety of molecules and transcription factors. For example, the most important of all being HNF1 alpha. And problems with these transcription factors, which I'm going to tell, are very important in the setting of monogenic forms of diabetes like MODY, maturity onset diabetes in the young, where there will be problem with these transcription factors so that there will be defective beta cell function and synthesis of insulin rather than insulin resistance or insulin deficiency. Clear? So HNF1 alpha is very, very important because deficiency of this or problems in this is going to result in one of the most common types of MODY, that is MODY type 3, which is the most common form of MODY in India and around the world, which we'll be discussing subsequently. And HNF1 alpha is further regulated by two more hepatocyte nuclear factors called as HNF4 alpha and HNF1 beta. All right. And the insulin gene promoter is also regulated by another important transcription factor called as ND1, otherwise referred to as NeuroD1 or neurogenic differentiation factor 1. And the third one that is important for the proper functioning of the insulin gene promoter is PDX1, which is also important for the pancreatic development during the embryonic life. And PDX1 is further influenced by HNF4 alpha once again as well, so that all these transcription factors play a very substantial role in the transcription of insulin gene, thereby subsequent production of insulin molecule. So problems in these transcription factors, as I told you, will result in monogenic forms of diabetes like MODY, maturity onset diabetes in the young. And as the insulin gene is transcribed into an mRNA and which is subsequently translated into a protein, they are not going to directly produce insulin. Initially, they produce a precursor molecule called as pre-proinsulin. So what is pre-proinsulin? Is going to contain the A chain and B chain and the two disulfide bonds between them, and it's going to have an inactive C peptide and a N-terminal end which is also inactive. And subsequently, this pre-proinsulin will be proteolyzed, where you will be removing the N-terminal end and resulting in a new molecule called as proinsulin, which will be containing the A chain, B chain and the C peptide alone. Subsequently, this proinsulin also will be acted upon by another enzyme called as proconvertase 1, which we are familiar about it because we have discussed in detail in the adrenal insufficiency chapter itself, where proconvertase 1 is also important for breaking and cleaving the POMC molecule in the pituitary gland as well. So proconvertase 1 will split the C peptide separately, which will be stored along with the insulin molecule only, where you will have an active insulin molecule which is having A and B chains, and both C peptide and insulin molecules will be stored in the vesicles within the beta cells of the pancreas. All right. So if you take the clinical activity of insulin at 100%, C peptide has 0% activity, N-terminal end has 0% activity, but if you take proinsulin as a whole, they are going to have 5% activity compared to that of the insulin molecule. But whereas pre-proinsulin will not have any biological activity, that is, it has only 0% activity. There is no activity for pre-proinsulin. But proinsulin still has 5% of insulin activity. We know how insulin is going to be released. It's not going to be released alone. It's going to be released along with C peptide, because insulin is stored along with the C peptide in the vesicles. And more importantly, insulin and C peptide are released in equimolar concentrations, 1:1 ratio. Why this point is important? Because we are going to use C peptide as a surrogate marker of insulin release and beta cell function, especially in the setting of diagnosis of type 1 diabetes mellitus. Why you are using C peptide as a surrogate marker of insulin release and beta cell function and not insulin itself? The reason is because C peptide is more stable in its circulation. At the same time, it's going to have a relatively longer half-life because it is not rapidly metabolized. But on the other hand, insulin is a little unstable in the circulation because it's going to have a shorter half-life and it's going to be rapidly metabolized. And that's the reason why it's going to have a shorter half-life. And that is why we are going to use C peptide as a surrogate marker for insulin release and beta cell function, which is really, really important in the setting of diagnosis of type 1 diabetes mellitus. Then next question automatically comes, how insulin is released in the first place? What are the triggers for insulin release? Let us see. So there are a lot of triggers. First, we are talking about the basic biochemical triggers. One is the glucose, of course, the most important trigger for insulin release. Second one, we have amino acids, which are also decent triggers for insulin release from the beta cell. And third, we are also going to have free fatty acids as very important triggers for insulin release. And we have neural triggers, and we are going to have endocrine triggers as well, which we'll be discussing subsequently. First, let us see the biochemical triggers, of which the glucose is going to be the most important. Glucose, first of all, should enter the beta cells to produce insulin release, and that entry into the beta cell is granted by a very important transporter called as GLUT2 transporter. So we have to know some details with regards to the GLUT2 transporter, and at the same time about other glucose transporters as well, because there are 7 important glucose transporters in the body which are very important for your exams. The 5 glucose transporters, GLUT1, 2, 3, 4 and 5, and 2 sodium glucose transporters which are present in the small intestine and the kidneys. So let us start with the GLUT1 transporters. GLUT1 transporters basically are present in all the tissues, with special preference to the red blood cells and the blood-brain barrier, where presence on the red blood cells is even more important because red blood cells thrive exclusively on glucose. There is no other fuel that they can use for energy production. So clear? So then we have GLUT2 as a very important transporter, which is typically seen in the liver, beta cells of the pancreas, and they can be also seen to a small extent in the small intestine. And what is the importance of GLUT2? GLUT2, one additional point that you have to know is they're going to have a low affinity for glucose. They don't have that much affinity for glucose, which means you can imagine like they're going to have a higher Km from enzyme kinetics, even though you cannot equate exactly, but you can imagine like they have a higher Km, so that they tend to have a lower affinity. Then we have GLUT3 receptors, which are typically seen in the neurons, placenta, and this is a very important MCQ, and in the testis as well. Remember the fact that this GLUT3 transporters tend to have a higher affinity for glucose, and that's important especially in the setting of a neuron which thrives mostly on glucose, and even at lower glucose concentrations they have to effectively extract glucose from the circulation, and that's how they tend to have a higher affinity. We know that. You can imagine like they are going to have a lower Km, so higher affinity from enzyme kinetics. GLUT4 is the most important transporter as far as diabetes is concerned, because GLUT4 is the only glucose transporter that is going to be insulin dependent, which means the activity of the GLUT4 transporter is going to be completely insulin dependent, which means only in the presence of insulin you're going to have good activity of GLUT4 transporter. And the tissues that are going to have GLUT4 in high concentrations are the skeletal muscle, which is the most important, then followed by adipose tissue, which is also important, then followed by the cardiac muscle, heart. Then we have GLUT5 transporters, which is typically seen in the small intestine, enterocytes, where they are involved in fructose transport rather than glucose transport, and that's the take-home point here. Then we have 2 sodium glucose transporters, SGLT1 and SGLT2, where SGLT1 is typically present in the enterocytes, that is especially in the small intestine, where they're involved in glucose transport, whereas SGLT2 is involved in the glucose reabsorption in the proximal collineated tubule of the kidneys. And remember the fact that both SGLT1 as well as SGLT2 transporters are ATP dependent as well as sodium dependent. Sodium as well as ATP dependent. There are probably some examples of secondary active transport as well. And we have a molecular target for diabetes mellitus treatment where you're going to inhibit SGLT2 by giving certain group of drugs called SGLT2 inhibitors, which are famously called as gliflozins. We have currently 3 gliflozins. One is ganagliflozin, empagliflozin, and third is dapagliflozin. All of 3 are SGLT2 specific inhibitors. But we have a broad spectrum inhibitor, SGLT inhibitor, that is sotagliflozin, which is a combined SGLT1 as well as SGLT2 inhibitors, which is not yet available in Indian market, but it might be soon available. But SGLT2 inhibitors are the ones that are currently ruling the diabetic market in the country. So you have to know in detail about that. So what SGLT2 inhibitors do, we are going to see in detail in the therapeutic section. But anyways, SGLT2 inhibitors are going to induce a therapeutic glycosuria. So how they are helpful? So we know SGLT2 inhibitors can block the sodium glucose transport. This is SGLT2 in the PCT of the kidneys. Once you block them, you are resulting in a therapeutic glycosuria. And just because it prevents the reabsorption of glucose from the kidney and wasting glucose in the urine, they can produce a improvement in the diabetes. So look from where to where we have progressed. Initially, 1 century back, we have thought that glycosuria is the reason for developing a particular disease, and controlling the glycosuria was the initial strategy. Now we have moved on to a fact that we are inducing glycosuria therapeutically and treating diabetes mellitus. So that's how science has advanced, our understanding has advanced. And anyways, this is a very important breakthrough as well. And GLUT4 is the most important as far as insulin resistance and diabetes mellitus is concerned. So we are talking about GLUT4 in detail in the type 2 diabetes mellitus section. So anyways, now once glucose has entered the beta cells of the pancreas, of course through GLUT2 transporters in the beta cells, this glucose will be taken up by a very, very, very specialized enzyme called as glucokinase. And this is going to serve as a sensor for glucose levels that are entering the beta cells. So that's very special, and it's going to convert the glucose to glucose 6-phosphate. And this is not special at all, because conversion of glucose to glucose 6-phosphate happens in any other tissues through glycolysis. But this glucokinase is specialized enzyme here and in the liver, because they are going to perform this sensing function. They're going to sense how much glucose is coming into the beta cells of the pancreas. So later on, this glucose 6-phosphate will be absorbed into glycolysis and the Krebs cycle and the TCA cycle, and they're going to produce ATP, generate a lot of ATP, which we'll be discussing subsequently. But what is the importance of this glucokinase enzyme? So we have to see how different is this glucokinase from the routine hexokinases that is present in other tissues. Remember the fact that the name hexokinase itself tells you one story, that they are not specific for glucose alone. They are going to take up all the hexoses as substrates. There is no substrate specificity. They're going to take glucose, galactose, as well as fructose, and all the hexoses will be substrates for hexokinase. That's why it's called a hexokinase. Whereas glucokinase, on the other hand, is specific for glucose only. That's why it's called a glucokinase. It is relatively substrate specific. All right. And at the same time, glucokinase enzyme is little tissue specific as well, where they're going to be exclusively seen in the beta cells and the liver. Whereas hexokinases can be seen in all the tissues. The main role of glucokinase is to perform the sensing function. And very importantly, it can be induced by insulin. That's very important. It can be activated by insulin, which means there is a hormonal effect as well. There is no such effect for hexokinase. So this is important to understand one thing, because insulin action is going to convert glucose to glycogen. So that's why glucokinase is there. It can be induced by insulin, where this glucokinase can be used to convert to glucose 6-phosphate, which is subsequently absorbed towards glycogen production. Whereas hexokinase converting glucose to glucose 6-phosphate is important for absorbing this glucose 6-phosphate towards Krebs cycle and glycolysis, producing more energy. So understanding is very simple. Glucokinase induced by insulin, especially in the liver, converting glucose to glucose 6-phosphate, and this glucose 6-phosphate produced on behalf of insulin induction of glucokinase will be absorbed towards glycogen production. Whereas this hexokinase, not induced by insulin, converting glucose to glucose 6-phosphate, and this glucose 6-phosphate molecule will be absorbed towards glycolysis and Krebs cycle, producing energy. That's how it works. And in the beta cells and the liver, glucokinase is going to serve as a sensor as well. So they're going to perform that sensing function of sensing how much glucose is coming into the cell. Hexokinase doesn't have any sensing function. Now, hexokinase has some allosteric inhibitors also in the form of glucose 6-phosphate, which is nothing but a product of hexokinase. That itself acts as an allosteric inhibitor for hexokinase, whereas no allosteric inhibitors exist for glucokinase. When you translate this into enzyme kinetics, glucokinase is going to have a higher Km and a subsequent higher Vmax, which means they are going to have a lower affinity. We know Km is inversely proportional to affinity of the substrate. So they're going to have a lower affinity for glucose as a substrate. Whereas hexokinase is going to have a lower Km and a lower Vmax subsequently, which is going to have a higher affinity for glucose, for that matters. So glucokinase is more specific for glucose, but even though they have a little bit lesser affinity, but as hexokinase has a lesser specificity for glucose as substrate, but they have a higher affinity. So somehow glucose has entered the beta cells and has got converted to glucose 6-phosphate by sensing enzyme called glucokinase, and then it has been converted to ATP by glycolysis and Krebs cycle. And this ATP has one important effect on a very, very important channel that is called as ATP sensitive potassium channels. I'm going to write as KATP channels are nothing but ATP sensitive potassium channels. The function of these channels is to move the potassium out of the cell, and once ATP comes and binds with this ATP sensitive potassium channels, KATP channels, they're going to block the potassium efflux, resulting in more and more potassium accumulation within the beta cells. Once potassium accumulates within the beta cell, they're going to depolarize the membrane because these are positive charges, and this depolarization will activate the calcium channels subsequently, and there's going to be more calcium inside the cell, and this more calcium can release glutamate. Glutamate can boost the insulin releasing function, but we're not talking about that right now. But calcium itself can break these vesicles, dock these vesicles, and they can produce insulin and C-peptide release. Clear? So what you're seeing here is a very elegant mechanism where glucose producing more ATP causing more insulin release. It's glucose dependent insulin release. That's it. So this is a very protective mechanism as far as physiological homeostasis is concerned. Because whenever the glucose levels are low in the blood, there will be subsequently low insulin production, which is very good because then only you can avoid further hypoglycemia. But this mechanism can be surpassed by sulfonylureas because sulfonylureas also does the same function as that of ATP. They bind to the ATP sensitive potassium channels like ATP, and they block the ATP sensitive potassium channels, and they produce more insulin. But here there is no ATP, still you will have insulin production, which means even in the setting of hypoglycemia, there will be low glucose outside the beta cell in the circulation. Inside the beta cell, there will be low ATP production, but still sulfonylureas, because they're binding consistently, they will produce more insulin, worsening and augmenting the hypoglycemia. So clear? So sulfonylureas are producing glucose-independent insulin release, which is exact opposite to physiological release of insulin. So that's why sulfonylureas have higher propensity to cause hypoglycemia. But physiologically, it should be glucose-dependent insulin release. Sulfonylureas, glucose-independent insulin release. Now let us dissect this potassium sensitive ATP channels in a little bit more depth and detail, because many of these genes are involved in neonatal diabetes. So potassium sensitive ATP channels, ATP sensitive potassium channels have 8 subunits, 4 and 4. Out of 4 is made of this invert rectifier potassium subunits, which is further divided into 2 types. One is KR6.1, which is clinically more important, KR6.2. KR6.1 is coming from a gene called KCNJ8, and KR6.2 is coming from KCNJ11. And remaining 4 subunits are going to be made of sulfonylurea receptors, SUR. These subunits, proteins, are called as sulfonylurea receptors, which is of 3 types. One is SUR1, type 1, and second is SUR2A, and third is SUR2B. Of which SUR1 is clinically more relevant because this is coming from ABCC8 gene, and this is the receptor where your sulfonylurea also really binds, SUR1, which is coming from ABCC8, which is a very important gene as far as neonatal diabetes is concerned, which we'll be discussing subsequently in the classification and types of diabetes. Having discussed in detail about the ATP sensitive potassium channels in detail, let us move on to the neural control of insulin release from the beta cells. Typically, it comes from the autonomic nervous system, which can have either control in the form of parasympathetic action or in the form of sympathetic action. Parasympathetic action through the vagus is essentially going to increase the insulin release from the beta cells, which is a very important point, whereas sympathetic action will have varied effects depending on the type of receptor, if it's alpha 2 receptor or beta 2 receptor. Remember, action of sympathetic neurons on the alpha 2 receptors will actually result in reduced insulin secretion and insulin production, whereas action of sympathetic neurons on the beta 2 receptors is going to increase the insulin secretion. And many students ask me then how beta 2 agonists can produce hyperglycemia rather than hypoglycemia. That's true, beta 2 agonists actually cause hyperglycemia. But the effect is not actually through pancreas, the effect is actually mediated through the liver. Because in the liver, beta 2 stimulation will result in increased gluconeogenesis. That's how beta 2 agonists produce hyperglycemia and not hypoglycemia. Similarly, theophylline also can produce hyperglycemia in toxic scenarios. This is how. And this alpha 2 mediated reduced insulin secretion is clinically very important in one setting, like pheochromocytoma, where excessive epinephrine action on alpha 2 receptor is going to reduce the insulin secretion, resulting in more glucose, hyperglycemia. That's how pheochromocytoma and higher epinephrine is going to cause hyperglycemia in the body. And finally, we have endocrine control as well. Right from the first year, we know there is one hormone that's going to suppress any hormone release, that is somatostatin. And of course, somatostatin is produced by the D cells within the pancreas as well as many other places in the body where they're going to have a suppressing effect on hormone production and release. And there are some hormones that can increase the insulin release, like for example, the incretins, which are the most important. And we know we have two types of incretins. One is GLP-1 and second is GIP, out of which GLP-1 is the most important because it is at least 10 times more potent than GIP. GLP-1 stands for glucagon-like peptide 1 and GIP stands for gastric inhibitory peptide. And the details of incretins we are going to discuss extensively later on, but at the same time we have had a little bit of discussion in the obesity chapter itself. And then insulin release can be increased by growth hormone, cortisol, as well as estrogen, estradiol. All right. Now let us see the insulin response that happens in response to a glucose load or a nutrient load. So whenever the patient takes a food, obviously we know there will be a baseline insulin in the body, and the moment the patient takes food, within 5 to 10 minutes there will be a surge in the insulin release. So this is what we refer to as the phase 1 or the immediate phase of insulin release, or a fast phase of insulin release, which is basically due to release of the preformed vesicles that is already present in the beta cell. Then which will be subsequently followed by insulin release that happens slowly over a period of minutes to hours. So this is slow release of insulin, phase 2 of insulin release, which is typically due to new production of insulin molecules within the beta cell. And next we have to know in a short way about this incretin effect. So what do you mean by incretin effect? So this is an incredible effect indeed. And the discovery of this effect led to formation of new drugs like DPP-4 inhibitors and GLP-1 analogs, and the basis of all the drugs what we are having right now. So what is incretin effect? So initially what they thought is the IV glucose must be the one which is going to produce faster and more durable insulin response from the beta cell. But what they found out is otherwise. So they have made a research where they gave IV glucose. So once you gave an IV glucose, this was the insulin response. Let us assume. And they compared with the oral glucose. And after giving oral glucose, which was a big surprise for them, this was the insulin response, which means the insulin response was much, much, much higher with oral glucose compared to the IV glucose. So why is the difference? So this difference must be due to some molecules that are present in the gut, which is actually coming out in response to an oral nutrient load or oral glucose that is going and stimulating the beta cells to produce that excess insulin, which are shown in the yellow shade here. And this effect is what we refer to as an incretin effect. And later on, subsequently, they know that in response to oral glucose load, some additional molecules are produced by the gut in the form of incretins, that is GLP-1 and GIP, which is responsible for production of this incretin effect. And they also have found out that in type 2 diabetes mellitus patients, this incretin effect is actually blunted. The amount of insulin that is released in response to oral glucose load in patients with type 2 diabetes mellitus is actually much lower. So you want to push this incretin effect to the maximum, to the previous best once again. So that's why we are using this incretin related drugs like GLP-1 analogs or DPP-4 inhibitors. So that's the basis of using incretin drugs there. So let us discuss in detail in the therapeutics of type 2 diabetes mellitus section. Now let us move on. Now the question comes, what is insulin in the first place? So I'm going to tell insulin in one word, that it is an anabolic hormone. So what do you mean by that? So insulin is released as a sign of a well-fed state or a high energy state in the body. So which means, what is the function of that? Naturally, any organism or any living thing, whenever they are feeding too much, that excess energy should be stored for future use. That's what insulin does. Insulin tries to take this high energy sources and tries to store it for future use. So for example, glucose is such one example of a high energy molecule which will be converted to glycogen and it will be stored for future use in the form of glycogen in a process called glycogenesis, where insulin is going to activate a lot of enzymes in this pathway of glycogenesis, like it can activate glucokinase in the liver, which will produce glucose 6-phosphate, which will be subsequently sucked into the glycogenic pathway, and insulin also activates the glycogenic pathway by stimulating the glycogen synthase enzyme as well. Similarly, this free fatty acid production itself can be augmented by insulin through acyl-CoA carboxylase and fatty acid synthesis, which we'll be describing subsequently. And this formed free fatty acids will be converted to triacylglycerol, where insulin prevents the lysis of triacylglycerol so that it stimulates the storage of this free fatty acids as energy stored in the adipose tissue as triacylglycerol. That's why insulin is lipogenic in nature. Free fatty acid is also a very, very energy-rich compound. And similarly, amino acids are prevented from getting lysed, thereby it helps in protein building within the muscle. So overall, insulin is an anabolic hormone. That's what I'm trying to tell. Similarly, without insulin, if the body doesn't have insulin, what really happens? So in the setting of physiologically, what happens first? So it's a clear-cut catabolic state. So where glycogen will be lysed to produce glycogenolysis, which is going to produce excessive glucose in the blood, and your lipids will be lysed to produce free fatty acids, which will also increase in the circulation, which will be subsequently sucked into the liver to produce ketone bodies. This is very important in the setting of starvation and fasting, where you will have low insulin, because that's a sign of low energy in the body, where the stores has to be mobilized. So where this free fatty acids is a very important energy source for many tissues in the body. And once again, liver's production of ketone bodies from free fatty acids is also important, because ketone bodies also act as an alternate fuel source. But this becomes pathological in the setting of pathological insulin deficiency, like type 1 diabetes mellitus, where this excessive production of ketone bodies is resulting in diabetic ketoacidosis, which we'll be discussing subsequently in the subsequent chapters. And finally, insulin is the one that prevents the muscle breakdown, I told you. But in the absence of insulin, you're going to get muscle breakdown, and you're going to release amino acids into the circulation. And these amino acids are going to either enter gluconeogenic pathway or ketogenic pathway, or both. Because certain amino acids are gluconeogenic, certain amino acids are ketogenic, and certain amino acid catabolism might be combined gluconeogenic and ketogenic. So which we'll be discussing subsequently. Remember, so excessive glucose in the body can be due to accelerated glyconeogenesis or accelerated gluconeogenesis, which is the most important in the setting of insulin deficiency, or it could be due to reduced glucose uptake by the peripheral organs like skeletal muscle or adipose tissue, which rely on GLUT4 transporters for glucose uptake, which in turn is going to rely on insulin because they are insulin dependent. And I think with the discussion we have already had, it's very clear that insulin is an anabolic hormone, and absence of insulin is a clear-cut catabolic state. Let us see how all this is going to work. And for that, we need to understand the basic biochemical processes in the first place. I'm not going to discuss about the entire biochemistry in this lecture, because otherwise it will be so tedious for you to understand. But I'm going to tell you the basic process, and we have to know it in an integrated fashion so that we have to understand the diabetes better. So that I'm going to keep glycolysis as a backbone. Yes, it is a backbone around which we're going to play around a lot of pathways. Let us see how glycolysis is going to be the backbone. And this is the Emden-Meyerhof pathway. It is the father of all the pathways. And to discover all the steps in this pathways, it took almost over a century to delineate all the steps. So let us respect this pathway, because there are a lot of scientists who have been involved in this. So first, you start with the energy-rich compound, that is glucose, which is the basic monosaccharide and the basic energy compound that our body requires. So glucose will be converted to glucose 6-phosphate in an irreversible step, catalyzed by either a glucokinase or a hexokinase, depending on the tissues which you're going to deal with. And it's an ATP consuming process, the details of which we don't want it, because we wanted only the things that are concentrated with respect to diabetes mellitus. So we know that glucokinase can be induced by insulin. And this induction by insulin is very important, because they're going to produce excess glucose 6-phosphate in the liver. You know, glucokinase is going to be present in the beta cells of the pancreas as well as the liver, where in the liver and the beta cells of the pancreas, they're going to act as a sensor for glucose. And at the same time, in the liver, this activation by insulin is very important to produce excessive glucose 6-phosphate, because this excessive production of glucose 6-phosphate in the liver will be sucked towards glycogen production. So how is this possible? So let us see. First, imagine a very logical way. You're taking a food which is having a high glucose and probably high amino acid content, and first the food reaches the portal circulation where you are reaching the pancreas first. Through incretins, the signal will be even more faster, where the pancreas senses that and releases a lot of insulin. So now the portal circulation will contain a lot of insulin. That's called portal insulin, which is very, very important. And it's going to have a high amount of glucose content as well. So this high glucose along with high insulin is going to the liver through the portal circulation, where this insulin is going to stimulate the glucokinase enzyme so that there will be too much of glucose 6-phosphate production from excessive glucose that is already coming from the food. So now you know it's a high energy signal. So this excessive glucose 6-phosphate production is a key for glycogen production, because this much amount of glucose 6-phosphate cannot be sucked down the glycolytic pathway. So there will be spilling over, which will be moving towards glycogen production. That's how it works. So how they're going to produce glycogen? So first glucose 6-phosphate will be converted to a compound called glucose 1-phosphate in a definitely reversible step, no doubt about that, by an enzyme called phosphoglucomutase. I'm writing in a short form, phosphoglucomutase, PGM. And glucose 1-phosphate will be further converted to UDP glucose in a irreversible step, and UDP glucose will be further converted to something called a glycogenin in another irreversible step, catalyzed by a very, very important enzyme called as glycogen synthase. This is a very, very important enzyme, glycogen synthase, because this enzyme is under the control of insulin and can be activated by insulin as well. Clear? So what insulin does cleverly is the fact that it produces excessive glucose 6-phosphate and sucks that glucose 6-phosphate towards glycogen production. Simple. In the liver. So once glycogenin is formed, this can be branched by producing branching points and can produce a mature glycogen. And to produce this, you need a branching enzyme. That's called a brancher. So we don't want that unless and until we are talking about glycogen storage disorders. So now this glycogen can be broken down in times of need to glucose 1-phosphate by a process called glycogenolysis. And there are two enzymes that are important for glycogenolysis. One is, of course, the debranching enzyme, because you have to break down the branching points once again. So you need the debrancher. And you will be needing another enzyme called glycogen phosphorylase as well. There are two types of glycogen phosphorylase, one in the muscle phosphorylase, and second is the liver phosphorylase, which is not important right now. So let us assume there is something called a phosphorylase. This phosphorylase enzyme once again is under a good hormonal control, where it will be actually be repressed by insulin, inhibited by insulin. And of course, phosphorylase enzyme will be activated by counter-regulatory hormones like glucagon, and at the same time glycogen synthase will be inhibited by counter-regulatory hormones like glucagon. The net effect is, in well-fed states, high insulin states, glucose is converted to glycogen in the liver and probably in the muscle, and insulin of course is going to inhibit the glycogen breakdown and mobilizing these energy stores. Whereas in fasting states there will be excessive of counter-regulatory hormones, where counter-regulatory hormones are trying to stop the glycogen production by inhibiting glycogen synthase and increasing the glucose production by mobilizing the energy stores from glycogen by a process called glycogenolysis by activating the phosphorylase enzyme. And the compound UDP glucose is going to have multiple other associations with other pathways like uronic acid pathway, which is not important right now for our diabetes or hypoglycemia understanding, because it's a hardcore biochemistry. We're not going to discuss that right now. And the UDP glucose association with galactose metabolism is what is important, because we have to understand how galactosemia can produce hypoglycemia. I'll be describing later on, but let us see the pathways now. Galactose metabolism. So how UDP glucose is linked with galactose metabolism. Let us take the UDP glucose, which is actually going to get converted to UDP galactose using an enzyme called GALT enzyme, which is a very, very important enzyme in the galactose metabolism pathway. How glucose can be converted to galactose? You need to have galactose for that. So, of course, galactose comes from the diet, especially dairy foods. Galactose will be converted to galactose 1-phosphate by galactokinase enzyme. I'm not going to discuss about that. This galactose 1-phosphate can be converted to glucose 1-phosphate by GALT enzyme. So what GALT enzyme does is very simple. It takes UDP glucose and galactose 1-phosphate coming from the galactose metabolism and converts these compounds to UDP galactose and glucose 1-phosphate. UDP galactose later on is going to form lactose. They can produce glycoproteins. They can be useful in producing glycolipids. They can be useful in producing glycosaminoglycans, which is none of our business right now. But this glucose 1-phosphate that is produced by GALT enzyme can be reintegrated back into either the glycolytic pathway or to produce glucose from glucose 6-phosphate, because once glucose 1-phosphate is formed, the phosphoglucomutase enzyme can easily convert that to glucose 6-phosphate, whether it will be sucked into the glycolytic pathway or it will be sucked to produce glucose, or it will be sucked back to produce glycogen, depends on the energy demands of the body. So we're not going to discuss about that, but final pathway is production of UDP galactose and glucose 1-phosphate by this galactose metabolism. And the most important enzyme in this pathway is GALT enzyme. So glucose and glucose 6-phosphate has other associations as well. So first, let us see the pathological associations. So glucose in extremely excess amounts can be converted to sorbitol. But remember, only in high amounts. High amounts of glucose, which cannot be taken by, that much amount of glucose cannot be taken by glycolysis, that can spill over and can enter another pathway called polyol pathway. So where you have a very, very important enzyme called aldose reductase, which is going to convert glucose to sorbitol. And once sorbitol is formed, this can be acted upon by another enzyme called sorbitol dehydrogenase, which can produce fructose. And remember, the sorbitol is the one that is implicated in a lot of microvascular complications in diabetes, which we'll be discussing subsequently, polyol pathway. And this happens in the setting of hyperglycemia due to diabetes. So these are pathological pathways you're talking about. And what about this glucose 6-phosphate? Does it have any role? Yes, it does have a role. Glucose 6-phosphate, we know very well, it can be shunted towards another pathway called HMP shunt because they form 6-phosphogluconate through a very important enzyme called G6PD, which is a rate limiting step of this step, that is glucose 6-phosphate dehydrogenase enzyme, which of course is going to produce NADPH from NADP. That's a very, very crucial thing which we have discussed already in hematology section itself. And I can write this 6-phosphogluconate will be utilized to enter the HMP shunt, which is important for producing ribose sugars, which will be subsequently integrated into the nucleotides and the DNA synthesis. So you have so much of associations. In just 2 steps, we have 4 associations with glycolysis. So let us see what is the association with the next step. So of course, the next step is going to be an reversible step where an isomerase enzyme is going to convert glucose 6-phosphate to fructose 6-phosphate. And fructose 6-phosphate has its association with another pathway called hexosamine pathway. Hexosamine pathway. What is hexosamine pathway? You're going to form something called amino sugars. One of the best examples of amino sugars is N-acetyl galactosamine, GLC-NAC, that is N-acetyl galactosamine. And these amino sugars are very, very important for post-translational modifications. Normally itself, there will be some post-translational modification of proteins. One of the examples is addition of this amino sugars. That is what we refer to as an hexosamine pathway. But in hyperglycemic states, there will be too much shunting of this fructose 6-phosphate because there will be so much of fructose 6-phosphate formation. There will be too much shunting towards hexosamine pathway, resulting in more amino sugar formation and unnecessary post-translational modifications, modifying certain proteins, resulting in pathogenesis in diabetes mellitus. So we'll be discussing subsequently once again. And next step is a very important step in glycolysis. That is a irreversible step. That's why I'm shading it. And that step is mediated by phosphofructokinase, which converts fructose 6-phosphate to fructose 1,6-bisphosphate. And this is actually a very important step because this step is induced by insulin. Insulin does it a little indirectly. There are 2 isoforms of PFK, PFK1 and PFK2. PFK2 is the one that is induced by insulin, not PFK1. Indirectly by multiple other processes, PFK1 also will be induced, resulting in more production of fructose 1,6-bisphosphate. So which means in areas where you can store energy, insulin converts glucose to glycogen. In areas where you cannot store energy, glucose will be sucked into the glycolytic pathway and many glycolytic intermediates. That's what the idea is. So ultimately, insulin has a strong hypoglycemic action. Glucose should not be there in the blood. That's what the idea of insulin. Okay, now we have produced fructose 1,6-bisphosphate. So now you're going to enter into a very, very important step, which is going to have multiple association with other pathways as well. That is the glyceraldehyde 3-phosphate step. So now I've written 2 everywhere. From here on, I have written 2 everywhere. Everywhere you can see I've written 2. Why I've written 2 is the fact that glucose is a 6-carbon molecule. So now with subsequent steps, you have broken the glucose into or catabolized the glucose into 2 3-carbon molecules. So the first example of 3-carbon molecules in the glycolytic pathway is glyceraldehyde 3-phosphate, which is a 3-carbon molecule. So from now on, from 1 glucose molecule, you are going to result in 2 molecules subsequently from glyceraldehyde 3-phosphate. So glyceraldehyde 3-phosphate has very, very important association with our fatty acid metabolism through dihydroxyacetone phosphate and glycerol 3-phosphate, which is going to shuttle between a lot of areas. So very important for fatty acid metabolism. And we have a glycerol shuttle to transport high energy electrons into the mitochondria. We have 2 shuttles, isn't it? Malate aspartate shuttle and glycerol shuttle. That is a hardcore biochemistry which has nothing to do with the diabetes as of now. So, but this glycerol 3-phosphate we are talking about is going to have an impact in the fatty acid metabolism, which we'll be discussing subsequently. And the other integration of glyceraldehyde 3-phosphate is going to come in the form of fructose metabolism, where fructose can produce fructose 1-phosphate through an enzyme called fructokinase, and further conversion of fructose 1-phosphate to glyceraldehyde 3-phosphate can be done by an enzyme called aldolase B. And remember the fact that deficiency of aldolase B will result in a disorder called hereditary fructose intolerance, which is implicated in hypoglycemia in the children. Clear? Which we'll be discussing subsequently in the hypoglycemia chapter. And let us move on to the next step. Glyceraldehyde 3-phosphate will be converted to 1,3-bisphosphoglycerate through a reversible step mediated by an enzyme called glyceraldehyde 3-phosphate dehydrogenase. And 1,3-BPG is converted to 3-phosphoglycerate by a very important step called phosphoglycerate kinase step, which is going to generate ATP. But RBCs have one additional shunt mechanism that is called Rappaport-Lubering pathway or Rappaport-Lubering shunt, which we have discussed in detail in the hematology section itself. Because RBCs have one special enzyme called 1,3-BPG mutase, which converts this to 2,3-BPG. And you know 2,3-BPG formation in RBCs is very, very important. This 2,3-BPG is the one that is going to shift the oxygen hemoglobin dissociation curve to the right, resulting in release of hemoglobin, because 2,3-BPG stabilizes the hemoglobin in the tense form, resulting in reduced affinity for oxygen, which means increased release of oxygen to the tissues. So it's important for the RBCs, only for the RBCs. This is what we refer to as Rappaport-Lubering cycle or Rappaport-Lubering shunt. It's present only in the RBCs because this mutase enzyme is specific and special to the RBCs. And one important key point that you have to note is the fact that if you make the 1,3-bisphosphoglycerate move towards the Rappaport-Lubering shunt, you will not result in the generation of ATP that is normally produced during this step. So RBCs has to decide. So in the sense, like in times of need, majority of the glucose molecules will be shunted towards Rappaport-Lubering cycle, resulting in reduced production of ATP. Or in the times of other events, RBCs will shunt most of the glucose molecules towards the routine glycolysis, where they will be needing more energy. So it all depends on what is the oxygen tension and a lot of other factors, not just based on just glucose in RBCs will move towards 2,3-BPG pathway. Some glucose will move towards 2,3-BPG pathway, and some glucose will be going towards the glycolytic pathways. All these things will happen simultaneously. And 3-phosphoglycerate will be converted to 2-phosphoglycerate in another reversible step done by phosphoglycerate mutase. And 2-phosphoglycerate will be converted to phosphanol pyruvate by another reversible step done by enolase. And this is a crucial enzyme because this enzyme is the one that is inhibited by fluoride. That's the basis of adding sodium fluoride to our vacuotinase that actually is intended to measure glucose values. Because otherwise the RBCs will utilize glucose to prevent the glycolysis happening in the RBCs. We add sodium fluoride, which inhibits the enolase enzyme. We know that. It's a gray vacuotoner, which we'll be discussing subsequently in the subsequent chapters. And phosphoenol pyruvate can be further converted to the final, the most important step, that is to pyruvate, mediated by an enzyme called pyruvate kinase, and it's an irreversible step. That's why I'm shading it. And it results in the generation of the ATP. That's why RBCs with pyruvate kinase deficiency cannot generate sufficient ATP, resulting in hemolysis and death. Okay. So now there are 3 reversible steps in the glycolysis. Let us number it from the beginning. So one is the glucose to glucose 6-phosphate step. Second one is the fructose 6-phosphate to fructose 1,6-bisphosphate step. And third one is the phosphoenol pyruvate to pyruvate step. Which means if you want to produce gluconeogenesis, which is usually exclusive for the liver, you need to reverse these 3 steps. So how you want to reverse these 3 steps? How you can reverse an irreversible step? By having some additional enzymes, special enzymes. So there are 3 special enzymes. For converting pyruvate to phosphoenol pyruvate first, you have an enzyme called pyruvate carboxylase, which is the most important enzyme, which converts pyruvate to oxaloacetate. Further conversion of oxaloacetate to phosphoenol pyruvate will be done by an enzyme called PepCK, that is phosphoenol pyruvate carboxykinase. Remember, gluconeogenesis can happen to an extent in the kidneys, to an extent in the small intestine, but the most important is the liver. And this pyruvate carboxylase is one of the very key steps and one of the first steps that's happening in gluconeogenesis, because without this you cannot enter the gluconeogenesis at all in the first place. So obviously this pyruvate carboxylase will be strongly inhibited by insulin, because insulin does not what? Gluconeogenesis. It's a strong inhibitor of gluconeogenesis. But it will be of course activated by counter-regulatory hormones like glucagon and epinephrine. There is no doubt about that. And once phosphoenol pyruvate is formed, other steps are automatic because they are reversible steps, but you will once again get stuck in the fructose 1,6-bisphosphate area, where once again you are having an irreversible step. So this has to be bypassed by another special enzyme that is called fructose 1,6-bisphosphatase. And this is another enzyme that is strongly under hormonal control. Of course, it will be inhibited by insulin and activated by counter-regulatory hormones like glucagon, epinephrine, or probably cortisol as well, because it's also involved in gluconeogenesis. And this step can be easily reversed, no problem, fructose 6-phosphate to glucose 6-phosphate by isomerase. But once again, you will get stuck here, where glucose 6-phosphate conversion to glucose becomes impossible without the presence of one important enzyme, which is almost exclusive for liver, called as glucose 6-phosphatase, deficiency of which will result in type 1 glycogen storage disorder called 1-Gierkes disease, which you have studied from first year biochemistry. And this is one of the very, very key steps, and glucose 6-phosphate molecule being very, very important link for gluconeogenesis, glycogenolysis, and other HMP shunt. So glucose 6-phosphate deficiency is going to result in serious hypoglycemias. We'll talk about that in hypoglycemia in infants and children later on. So glucose 6-phosphatase is a special enzyme that is almost exclusive for the liver. To an extent, it's present in small intestine, as I told you, but it's not present in the muscle. That is the reason why during glycogenolysis, because glycogen is present in muscle as well as the liver can produce glucose from this glucose 6-phosphate through glycogenolysis, but muscle cannot produce. Muscle can only utilize the energy that is coming from the glycogen by shunting the glucose 6-phosphate towards glycolysis, but they cannot produce glucose. But glucose can be produced by liver because it has glucose 6-phosphatase. That glucose will be poured into the blood. So during fasting sets, other organs can utilize it. Clear? Let us see the fates of the pyruvate, which is also equally important. So the first fate of pyruvate, we already know that it's going to get shunted towards gluconeogenesis, but we have a lot of other fates of pyruvate as well. Like for example, pyruvate can produce alanine, and this alanine production is usually due to an enzyme called alanine transaminase, otherwise referred to as SGPT, relatively specific for the liver, and it's a reversible step which utilizes NADH to produce NAD. Since it's a reversible reaction, I can put double arrows like this. And alanine can be further worked up towards amino acid metabolism, where they can be used to build up the proteins, or in fasting states, there is another cycle that exists called as a Cahill cycle. So what do you mean by Cahill cycle? So it happens in starvation states where the muscle provides alanine for gluconeogenesis for the liver. So this alanine will be entering the liver, resulting in formation of pyruvate because ALT is in high concentration in the liver. So once pyruvate is formed, because it's a starvation state, obviously the gluconogenic pathways will be very active, resulting in more glucose production. This glucose will be given back to the muscle, where the muscle gives alanine to the liver, liver gives glucose to the muscle. So this is what we refer to as a Cahill cycle, happens in starvation. And the third pathway for pyruvate is formation of lactate through another reversible step catalyzed by lactate dehydrogenase enzyme. So which is a very important enzyme as well. So where once again you're going to utilize NADH to produce NAD. So I can put a double arrow because it's a reversible step. So there is another integrated pathway during starvation here that's called a Cory's cycle. So where the muscle can produce lactate through glycolysis, and this lactate can be given to the liver. Liver produces pyruvate. From pyruvate they can produce glucose through gluconeogenesis, and this glucose will be given back to the muscle. Muscle utilizes this glucose for energy, and they're going to produce lactate. Once again the muscle pours lactate into the blood. That will go back to the liver. So this cycle between muscle and liver during starvation, between lactate, glucose and pyruvate, is what we refer to as Cory's cycle. Anyway, so we have seen 3 fates of pyruvate. Now the 4th fate is the most important one because it's an irreversible step. So that's why I'm putting a black shade. So remember, this pyruvate carboxylase step is also an irreversible step. It's not like it's a reversible step. Similarly, this 4th final step of formation of acetyl-CoA from pyruvate is also definitely a irreversible step. It is catalyzed by an enzyme called pyruvate dehydrogenase, PDH, which is strongly under the action of insulin. Strongly under the action of insulin, which can be actually activated by insulin. So pyruvate is going to produce more acetyl-CoA, isn't it? So in the presence of insulin. But this acetyl-CoA has multiple fates. Once again, acetyl-CoA can be utilized in the TCA cycle to produce citrate through an enzyme called citrate synthase, or obviously citrate can be converting back to acetyl-CoA through an enzyme called citrate lyase. That is also there. We are not going to discuss about that. Second pathway for acetyl-CoA is the fact that they can produce ketone bodies like beta-hydroxybutyrate and acetoacetate in the setting of certain enzymes like HMG-CoA, synthase and lyase. So these 2 are key enzymes for the production of ketone bodies. Acetyl-CoA can be shunted towards ketone body production. Or there is a third pathway. That is what is important for insulin. So seeing these 2 pathways, students will usually get confused. Insulin producing more acetyl-CoA from pyruvate. They might be thinking that insulin can produce excessive ketone bodies. It's very, very clear insulin cannot do that because insulin is a anti-ketotic hormone. So how insulin prevents this acetyl-CoA from getting converted to ketone bodies or sucked into the TCA cycle? In areas that are responsive to insulin. That's what is important. So this acetyl-CoA will be actually shunted towards fatty acid synthesis. That's what the most important point is. Fatty acid synthesis, because 2 enzymes are very important in this. One is acetyl-CoA carboxylase, which is going to convert this acetyl-CoA to malonyl-CoA, which is a very important step. And then you have a lot of enzymes like fatty acid synthase, which can convert this acetyl-CoA to palmitoyl-CoA, that is free fatty acid. And this enzyme, especially the acetyl-CoA carboxylase, ACC, is strongly under the control of insulin, which can be actually stimulated by insulin. Of course, this enzyme is inhibited by glucagon, there is no doubt about that. But this ACC can be strongly stimulated or induced by insulin. Why this is important? Because insulin produces excessive acetyl-CoA from glucose, especially in adipose tissue and the liver. But this acetyl-CoA that is produced in the effect of insulin will be sucked towards fatty acid production, not towards ketone production. So that's why insulin is strongly anti-ketotic by shunting the acetyl-CoA towards your fatty acid synthesis and not towards ketone body production. This happens in areas that are highly responsive to insulin. For example, liver is highly responsive to insulin. Adipose tissue, highly responsive to insulin. Muscle, responsive to insulin. But in the muscle, this will not happen. But in the muscle, usually this acetyl-CoA will be shunted towards energy production. But anyways, in the liver and the adipose tissue, this acetyl-CoA that is produced under the effect of insulin will be shunted towards free fatty acid production. And this has a strong connection with our glycerol 3-phosphate, as I told you previously, where glycerol 3-phosphate can combine with the fatty acid formed within liver or within adipose. We're not talking about in the blood. I'll tell you why this is important. So free fatty acid that is formed within the liver or adipose, this glycerol 3-phosphate is going to combine and they're going to result in, of course, monoalkyl glycerol, then dialkyl glycerol, and finally the trialkyl glycerol, which is nothing but triglyceride, which is a stored form of energy. And triglycerides fate depends on what is the organ that is generating it. So whether it is generated by the liver or whether it is generated by the adipose tissue. Water that is generated by the adipose tissue will be stored actually as fat for future needs, and water that is generated by the liver will be packaged and released as VLDL. The details of which we have discussed already in the lipid disorder section itself. This VLDL once again comes back to the adipose tissue where it will be releasing free fatty acids through a very important enzyme that is present in the adipose tissue called as capillary lipoprotein lipase. This is actually anabolic hormone. I'll tell you how. So free fatty acids can then be converted to triglycerol and which can be again stored in the adipose tissue, which means liver gives the triglycerides to the adipose and capillary lipoprotein lipase only helps in receiving the triglycerides from the VLDL through free fatty acids, which again gets converted to triglycerol in the adipose tissue and it is stored. So which means this capillary lipoprotein lipase you can imagine like a anabolic hormone. So that is actually to an extent is induced by insulin. Very important. Clear? So this is organ-specific fat synthesis, organ-specific fatty acid production, organ-specific fats. So now what happens in catabolic state? Suppose if you do not have insulin, obviously you know this adipose will get lysed and enter into a catabolic state where the stored triglycerides will be now converted to free fatty acids. And this step is mediated by a very important enzyme called hormone sensitive lipase, not capillary lipoprotein lipase. That's a different enzyme. Hormone sensitive lipase is a catabolic enzyme, not an anabolic enzyme like capillary lipoprotein lipase, which helps in actually building up the triglyceride stores in the adipose tissue. But this hormone sensitive lipase is going to catabolize, destroy the fat, and they are going to produce more free fatty acids. And please do understand the fact the free fatty acids that are produced by this particular catabolic step is actually in the blood, which means they are coming into the blood, not organ specific. That's very important once again. And hormone specific lipase, the name is apt because it's strongly under the influence of hormones, especially under the control of insulin. It's going to be inhibited by insulin. Yes, insulin is anti-catabolic, that's why. But of course, it can be stimulated by counter-regulatory hormones like epinephrine and growth hormone, definitely. So once excessive free fatty acids are formed in the blood and you do not have insulin and you have more counter-regulatory hormones, these free fatty acids can be forming more acetyl-CoA in a reverse step of fatty acid synthesis called as beta oxidation of fatty acids. And this is a very unregulated process, which means you don't have any hormonal regulation in beta oxidation. And the only regulated step for beta oxidation of fatty acids is actually before the beta oxidation step, that is hormone sensitive lipase. That's the only step that is actually regulated step for beta oxidation. Beta oxidation as such, it is not regulated by any hormones. So the more free fatty acids you form in the blood and you do not have insulin, means you're going to produce more acetyl-CoA. And since there is no insulin to take up this acetyl-CoA towards fatty acid production in the liver and adipose, this free fatty acids, of course, in the liver without insulin cannot go towards fatty acid production. In the sense they will be shunted towards ketone body production only. So that's why in the absence of insulin, you're going to produce more ketone bodies. That's why absence of insulin is a ketogenic state. Presence of insulin is an anti-ketogenic state because insulin will not allow the ketone bodies to form because in the liver, they're going to suck out all the acetyl-CoA towards fatty acid production, leaving nothing for ketone body production. And this is important in fasting and starvation states. You would have studied in biochemistry because ketone bodies are a very important source of fuel, alternate source of fuel. So what are the source of fuel we have? We have free fatty acids, which are relatively important source of fuel. We know that. And we have ketone bodies, which are very important alternative source of fuel. And at the same time, the usual source of fuel, which is the first preference for any tissue, is glucose for that matters. So what are the energy efficiencies? Basically, first we have a lot of energy donors. I mean, in the sense like electron carriers like NADH. Upon the electron transport chain, they're going to produce a theoretical maximum of 3 ATPs, but actually is only 2.5 ATPs. FADH2, that is UQH2, can produce a theoretical maximum of 2 ATPs, whereas actual is only 1.5 ATPs. This is based on the proton gradient. Acetyl-CoA can generate 12 ATPs according to biochemistry textbooks. That's theoretical maximum, but practically they can produce only 10 ATPs. Glucose theoretical maximum 36 ATPs, but practically only 30 ATPs. To be precise, it is 29.85 ATPs. Palmitate through beta oxidation, that is free fatty acid, when they get destroyed through beta oxidation, they can produce 129 ATPs. That's the theoretical maximum, but practically it is only 106 ATPs. So the richest source of energy is free fatty acid only, producing 129 ATPs per molecule. All right. Similarly, ketone bodies also can generate a substantial amount of energy. For example, acetoacetate can generate approximately 23 ATPs and beta hydroxybutyrate can generate approximately 3 ATPs. So they are energy-rich compounds, especially in setting of fasting and starvation. They are going to provide alternate source of energy. Now let us summarize the action of insulin. So what are the effects of insulin on glycolysis? Insulin is definitely going to induce certain enzymes in glycolysis. The most important is going to be glucokinase in the liver, and that's more important compared to the pancreas. And the second, it also going to activate the PFK step, and especially it induces the PFK2 enzyme. And what about the glycogen synthesis? Of course, it's going to stimulate the glycogen synthase enzyme, which is a rate limiting step there. What happens to glycogenolysis? Insulin definitely is going to inhibit the glycogenolysis by inhibiting one important enzyme called glycogen phosphorylase. In the gluconeogenesis step, insulin is going to obviously inhibit the gluconeogenesis. There is no doubt about that, where insulin can inhibit all the key enzymes. It can inhibit pyruvate carboxylase, it can inhibit fructose 1,6-bisphosphatase, and at the same time it can inhibit the glucose 6-phosphatase as well. These are the key enzymes for gluconeogenesis. And insulin is anti-ketogenic, and they are going to produce lipogenic effect. How they are going to do that? That's very important. In the fatty acid metabolism, they are going to activate the acetyl-CoA carboxylase and fatty acid synthase. Of course, the acetyl-CoA carboxylase is the most important. And insulin is also going to inactivate the hormone-sensitive lipase enzyme. By these two processes, insulin is considered to be strongly anti-ketogenic. They will not allow the ketone bodies to form. They're strongly anti-ketogenic. Fine, all right. So these are going to be the effects of insulin on different biochemical pathways. And all these things we have discussed in detail in the flowchart, which I have integrated in a detailed way. Now let us see what are the effects that are going to happen in the presence of absent insulin. This typically happens in the setting of a type 1 diabetes mellitus or absolute insulin deficiency. So let us start with gluconeogenesis. Obviously, the process is going to be reversed, where counter-regulatory hormones like glucagon and cortisol, at every step they can activate the gluconeogenesis and they can produce excessive glucose, which means glucagon and cortisol are very, very important counter-regulatory hormones to insulin with respect to the gluconeogenesis part, where they can activate all the basic steps and irreversible steps of gluconeogenesis, right from pyruvate carboxylase to fructose 1,6-bisphosphatase to glucose 6-phosphatase. Glucagon and cortisol, gluconeogenesis, very important. And apart from that, insulin, of course, is going to activate this glucokinase and phosphofructokinase. Without insulin, you will not be having activity of glucokinase at all, which means glucose cannot be converted to glucose 6-phosphate in excess in the liver, which means they cannot be taken to the glycogen pathways because there is no substrate available. So of course, glucose will rise in this step. And because the phosphofructokinase is also not active, the fructose 6-phosphate will be in excess, which will result in accumulation of substrates, and glucose cannot be utilized by the tissues as well, resulting in more glucose. Clear? That's how it results in hyperglycemia as well. And what about the pyruvate? Pyruvate cannot produce acetyl-CoA in the setting of insulin deficiency because PDH will not be active. So whatever pyruvate you have will be actually shunted towards the gluconeogenic pathways to produce phosphoenol pyruvate. But acetyl-CoA will be in excess. How acetyl-CoA is going to be in excess? Because the triacylglycerol cannot be stable without insulin, which means they will go for lipolysis, as I told you. Because hormone-sensitive lipase will become too active under the influence of epinephrine and growth hormone. These are counter-regulatory hormones as far as lipolysis is concerned. So they're going to produce excessive free fatty acids in the bloodstream. That is going to come to the liver. In the liver, you don't have insulin. So obviously, free fatty acid to acetyl-CoA formation through beta oxidation is an unregulated process. So you're going to produce excessive acetyl-CoA. And this excessive acetyl-CoA cannot be converted back to free fatty acid because there is no insulin to stimulate the acetyl-CoA carboxylase and fatty acid synthesis, which will be actually inactive. And once excessive acetyl-CoA is formed and it cannot be shunted towards fatty acid production in the liver and in the adipose tissue, they'll be actually converted to ketone bodies in the liver, which is a very important alternate fuel. So in the setting of fasting and starvation, but in the setting of type 1 diabetes mellitus, this can precipitate the development of diabetic ketoacidosis. And in the muscle and adipose tissue, obviously they cannot generate fat, so they will be utilizing this acetyl-CoA for energy. I mean, obviously, we have studied in the previous slide that acetyl-CoA can generate 10 to 12 ATPs. 12 theoretical maximum, 10 according to our latest studies. So we know there are some different hormones working differently to counteract the actions of insulin. And that's why these are called as counter-regulatory hormones. And let us see how they're going to work. So I'm going to start with glycogenolysis, gluconeogenesis, lipolysis, and we have ketogenesis. 4 processes that is happening. And there are 5 different hormones that have effect on this. One is the insulin, of course. Second one is the glucagon. And third one is the epinephrine. And fourth one is the cortisol. And fifth one is going to be the growth hormone. Of course, insulin is the only hormone that has effects on all of these biochemical processes, and its effect is to suppress all of them. And that is the reason why we have 4 counter-regulatory hormones work in synchrony to antagonize the action of insulin in the body. And what glucagon can do? Glucagon can increase the gluconeogenesis, glucagon can increase the glycogenolysis, and glucagon can increase the ketogenesis as well, but it has relatively no effect on lipolysis. That's what we're seeing. So what I showed is glucagon is effective in gluconeogenesis, glucagon is effective in glycogenolysis, and glucagon is effective in ketogenesis as well by actually inhibiting the acetyl-CoA carboxylase and fatty acid synthase enzyme. So what about epinephrine then? Epinephrine has a strong effect on activating the glycogenolysis. It has strong effect on activating the lipolysis by stimulating the hormone-sensitive lipase, and it has strong effect on activating the ketogenesis as well, but it has a relatively negligible effect on gluconeogenesis for that perspective, where I've shown you very clearly gluconeogenesis needs glucagon and cortisol, but epinephrine plays a very little role here. But epinephrine is very important in the setting of ketogenesis, and epinephrine is very important for the setting of lipolysis, and epinephrine is also very important in the setting of glycogenolysis as well. Similarly, cortisol is not going to play a very important role in lipolysis or ketogenesis or glycogenolysis, but they can strongly activate the gluconeogenesis. We have seen that already. Cortisol can activate the gluconeogenesis. At the same time, growth hormone has very negligible effects on glycogenolysis, gluconeogenesis, as well as ketogenesis, but it can actually activate the lipolysis. We know that we have been studying from the beginning of the endocrine system, which I have portrayed once again, where growth hormone is very important for activating the hormone-sensitive lipase and producing lipolysis. So that's the reason why we have 4 counter-regulatory hormones, and to counteract that big boy called insulin, you need 4 counter-regulatory hormones in the body. And we are moving on to the final nutshell, that is the integration of all these metabolic events that is happening. So this is the final biochemical pathways that I want to know. First, I'm going to start with the fed state. So what happens in the fed state? You're going to have high glucose and high insulin. So obviously, let us take, this is the liver, and this is the brain, and this is going to be the adipose tissue, and this is going to be the muscle. So let us see what happens in each and every areas. So the setting of fed state, that is high insulin and high glucose, this is what is going to happen, where the liver tries to take up the glucose, and in the setting of high insulin, they're going to produce excessive glucose 6-phosphate, and this obviously will spill over to produce glycogen. That's what happens. And of course, insulin is going to stimulate the glycogen synthase enzyme, resulting in more glycogen production. There are two reasons for that. And of course, they're going to go into the glycolysis steps as well, where they're going to produce pyruvate. And pyruvate, under the influence of pyruvate dehydrogenase enzyme, which is very active in the setting of high insulin, in the fed state, they're going to produce excessive acetyl-CoA. But please understand the fact this acetyl-CoA will be shunted towards fatty acid synthesis rather than ketone body production or energy derivation through TCA cycle. Of course, some of the acetyl-CoA will be shunted towards TCA cycle to produce energy that is necessary for the liver cell. But under the influence of insulin, a lot of acetyl-CoA can be shunted towards production of fatty acid as well. So these fatty acids obviously will be coupling with glycerol 3-phosphate, and you know glycerol 3-phosphate will be coming from glycolysis, because when the insulin shunts the glucose towards glycolysis more and more glycerol 3-phosphate also will be produced from glyceraldehyde 3-phosphate. So that's how insulin works. So under the influence of excessive fatty acid production and excessive glycerol 3-phosphate, you're going to result in more triglyceride production. More triglyceride means more VLDL, and this VLDL will be circulating in the blood, which will be taken by our friend, that is adipose tissue, by using an enzyme called capillary lipoprotein lipase, and which is going to convert this triglyceride in the VLDL to free fatty acids within the adipose tissue. And these free fatty acids will be converted to triglycerides once again, and it will be stored within the adipose tissue. And triglycerides getting converted to free fatty acids once again through hormone sensitive lipase is not possible in the fed state, because this enzyme will be inactivated by insulin. And at the same time, in the high insulin, adipose also can take up glucose, because GLUT4 is the most important transporter in adipose tissue, and insulin is going to activate the GLUT4 transporters. And once they take up the glucose, and they're going to form glucose 6-phosphate, and subsequently they're going to form more glycerol 3-phosphate, which is a very important product of glycolysis, and at the same time they're going to form acetyl-CoA as well. This will result in more production of fatty acids under the setting of insulin. So these fatty acids once again will be generating more triglycerol, which will be stored within the adipose tissue, which means adipose tissue can generate triglycerides on their own. At the same time, they can take the VLDL, and through that also they can generate the triglycerides. But fed state, high insulin is an energy storage kind of a scenario. So they're going to store the fat within them. And what happens in the brain? Brain, it's a very simple process where glucose is going to enter, become glucose 6-phosphate, becomes pyruvate, and they're going to enter the TCA cycle for energy. So very simple state. So there is nothing much going to happen in the brain. And in the muscle, glucose will be entering the muscle, resulting in glucose 6-phosphate, because this glucose entry into the muscle is actually insulin dependent, because muscle once again needs this GLUT4 transporters for taking up the glucose. So they form glucose 6-phosphate. Obviously, you form excessive glucose 6-phosphate means they will be shunted towards glycogen production in the muscle as well. And the glucose 6-phosphate can produce pyruvate. Pyruvate will produce acetyl-CoA under the influence of insulin. Acetyl-CoA will be shunted towards TCA cycle for the energy related purposes, for generating ATP. And they're also going to take up the amino acids. Under the influence of insulin, these amino acids will be shunted towards protein production. Rather than catabolism, they'll be anabolic. So that's what happens in the muscle separately. So this is what happens in a fed state: glycogen production, VLDL production, triglyceride production, and storage in the adipose tissue. And brain uses glucose as usual. Muscles are going for anabolic state, producing more glycogen and more protein. That's all. Now let us move on to lower energy states like fasting. Fasting is something like a short-term decline in the energy intake. So that's what we call it as fasting. Long-term decline in the energy intake, we call it as starvation. short-term decline in the energy intake is what we call it as fasting. So during fasting, we know there's going to be reduced energy intake by the particular person, so that there will be reduced insulin as well, because insulin means there is high energy in the body. If there is low energy, of course there's going to be low insulin, and there's going to be higher amount of counter-regulatory hormones that are going to be circulating. So let us see what's going to happen in these organs. And the same color coding, same organs, I'm not going to label once again. First thing that you have to understand in fasting states or probably in starvation states is the fact that the liver and the adipose will stop using glucose as a primary source of fuel. That's very, very important, because they come into the defense, and liver starts producing glucose for other organs, and triglycerides start producing free fatty acids as a source of energy for other organs. So they try to become a defense rather than utilizing glucose for their energy. So first, let us start with the adipose, where they have enough stores of triglycerides, which is going to be broken down by hormone-sensitive lipase to free fatty acids and glycerol. Of course, hormone-sensitive lipase will be more active here because there will be low insulin and high counter-regulatory hormones. And free fatty acids will be taken up by the adipose as well as by the muscle, because adipose will be now relying on the free fatty acid as a primary source of fuel, where free fatty acid through beta oxidation can be converted to acetyl-CoA, where acetyl-CoA definitely will enter the TCA cycle and can yield enough energy, like 10 to 12 ATPs, which we have discussed already. And muscle also switches its primary source of fuel to free fatty acids, where free fatty acids once again are going to enter the beta oxidation pathway, where they can produce acetyl-CoA, which can subsequently enter the TCA cycle to produce enough amount of energy. And free fatty acids can also enter the liver, where in the liver, excessive free fatty acids obviously will enter the beta oxidation pathway, resulting in production of excessive acetyl-CoA. And excessive acetyl-CoA, obviously now liver will start using this acetyl-CoA as a primary source of fuel. But at the same time in the liver, we already know that whenever there is an excessive acetyl-CoA in the liver, in the setting of low insulin and higher counter-regulatory hormones, obviously there is going to be one more process that's going to kick on, that is ketone body production, that is ketogenesis, which will be further utilized by the muscle. So obviously ketone bodies can yield acetyl-CoA, like acetoacetate is going to obviously get converted to acetyl-CoA, which can further enter the TCA cycle to yield energy. Acetoacetate, as I told you, itself can yield 23 ATPs. And what about this glycerol? Glycerol that is coming from the triglycerides as a result of lipolysis is going to come to the liver, where it can enter the gluconeogenic pathway to become glucose. How is it possible? Because I told an important link between glyceraldehyde 3-phosphate to dihydroxystrone phosphate to glycerol 3-phosphate to fatty acid metabolism. So glyceraldehyde 3-phosphate becoming glycerol 3-phosphate is important for triglycerol synthesis when it integrates with the free fatty acids. Similarly, when triglycerols are broken down, you are going to release free glycerol that comes to the liver to become glycerol 3-phosphate, reintegrated into the gluconeogenic pathway through dihydroxystrone phosphate, glyceraldehyde 3-phosphate, and subsequently gluconeogenesis to produce glucose. So that's a very important link. And at the same time, muscles can use glycogen to produce glucose 6-phosphate, but remember they cannot produce glucose because they don't have the glucose 6-phosphatase enzyme. So muscles does not contribute to the blood glucose, but they can use their own glycogen to produce glucose 6-phosphate, which will further enter the glycolysis in the TCA cycle to produce energy. And muscles can generate amino acids as well through proteolysis, and these amino acids are going to enter the liver. This is a muscle alanine cycle we're talking about. So alanine is going to enter the liver, which is going to form pyruvate, because now the reaction will be reversed in a low energy state. So through alanine transferase, alanine will convert to pyruvate, and most of the amino acids, gluconeogenic amino acids can come, which can become pyruvate, and pyruvate is going to get converted to oxaloacetate. Oxaloacetate is going to get converted to glucose. We know how it's going to convert to oxaloacetate using a gluconeogenic enzyme called pyruvate carboxylase. Under the absence of insulin and higher counter-regulatory hormones, your pyruvate carboxylase will be active, which is going to convert pyruvate to oxaloacetate. and which is going to form glucose through the gluconeogenic pathway, which I have described already. And this glucose is the one that will be utilized by the brain, which means still the brain is dependent on the glucose for its energy through the TCA cycle. And glucose can also come back to the muscle, where the muscle is going to use glucose as an energy source by shunting towards the glucose 6-phosphate pathway and the TCA cycle. So this is what we call it as a muscle alanine cycle or a Cahill cycle, which I have described already, where muscle provides alanine for the liver, where liver produces glucose, which can be utilized by the muscle. So this is the fasting state in a nutshell. So now we are having a starvation state where the person has not taken any kind of energy for a longer duration of time. So here there will be so much low insulin, which means undetectable insulin almost, and the muscle would have depleted the glycogen almost already, and there will be some more changes that will be happening. Let us see what are they. As usual, liver and adipose will stop using glucose as a primary energy source. So adipose tissue will be releasing free fatty acids and glycerol, where this glycerol will be used by the liver to produce glucose through the gluconeogenic pathway. And free fatty acids remain the primary choice fuel for muscle as well as adipose tissue to produce acetyl-CoA to generate energy through TCA cycle. And free fatty acids again in the muscle through beta oxidation, they are going to yield acetyl-CoA, which is going to generate energy through TCA cycle. At the same time, your free fatty acids are also going to enter the liver, where we know clearly these free fatty acids in the liver will become acetyl-CoA in the absence of insulin. And acetyl-CoA will be converted to energy in the liver, whereas this excessive acetyl-CoA also has another fate in the form of ketone body production in the setting of low insulin and higher counter-regulatory hormones, which means free fatty acids remain the primary source of fuel for liver as well. And they're going to generate excessive ketone bodies. And this time there is some few changes that will happen to the ketone bodies. Ketone bodies, of course, will be utilized by the muscle to generate energy through acetyl-CoA. And ketone bodies now become the primary source of fuel for the brain as well. So where they will be forming acetyl-CoA, which will be entering the TCA cycle to produce energy. But there are two things that we haven't noticed yet. One is muscle has spared the protein. Muscle has spared the protein completely, which means there will be no longer protein destruction to spare the protein. And at the same time, brain has started using ketone bodies as a primary source of fuel, and they have stopped using glucose as a primary source of fuel. Why this happens? Because this glucose has to be preserved for use by RBCs, because RBCs are something that cannot use any other alternative energy source except glucose, because they don't have mitochondria and they can use only glycolysis, and their machinery runs only with glycolysis. So that's why all the organs are trying to preserve and conserve the glucose for the RBCs while taking up alternative energy source. During starvation, brain starts using ketone bodies and the muscle stops using glucose as a primary source of fuel, and all these things try to spare the glucose for RBCs, and your muscle's primary source of fuel is free fatty acids, but it's also start using ketone bodies. Brain, primary source of fuel becomes ketone bodies, whereas adipose and liver and muscle, primary source of fuel tends to be free fatty acids. So this is what happens in starvation states. So this is the complete integration of metabolism which is happening between the fed state, fasting state and the starvation state. And these concepts are very, very important for understanding our diabetic emergencies or hyperglycemic emergencies like diabetic ketoacidosis. At the same time, this is also important for understanding hypoglycemia chapter in a very detailed way. So with this, I think we can stop here, and in the next chapter, we'll be going on to the further basics of insulin and the glucose in the form of insulin physiology, and what is the pathophysiology of diabetes in the form of glucotoxicity. That's what we're going to see in the next chapter.